Hi everyone, and welcome to the Pulmonary section of the Step 2 High Yield course. My name is Stephen Bagley and I will be your lecturer for this part of the course. In this first lecture, we're going to cover asthma, and we're going to discuss everything you need to know about asthma to score highly on the Step 2 exam. To begin, let's discuss the definition of asthma, which is sometimes referred to as reactive airway disease. Asthma is an abnormal bronchoconstriction of the airways. However, there are multiple other diseases that can cause abnormal bronchoconstriction of the airways. So what is it that differentiates asthma from the others? The answer is that asthma is characterized by reversible airway obstruction, which is secondary to bronchial smooth muscle hyperactivity. This reversible component of the airway obstruction is diagnostic of asthma as opposed to some other obstructive disease of the lung. However, there are several other components to asthma in addition to this reversible airway obstruction from the smooth muscle hyperactivity. These include airway inflammation, mucus plugging, as well as actual hypertrophy of the bronchial smooth muscle. As you might imagine, if all of these processes are going on over a number of years, it can actually lead to a chronic and irreversible airway obstruction. And in this chronic situation, asthma can be quite difficult to differentiate from other obstructive diseases of the lung. Overall, asthma is extremely common in our population. The etiology remains pretty much unknown, but there are some associations with atopic disorders as well as obesity. It is important for you to remember on Step 2 that the prevalence, incidence, and hospitalization rates of asthma are increasing in our population. While the underlying etiology of asthma remains unclear, there are several causes of acute exacerbations of asthma with which we are more familiar. The first of these are allergens, such as pollen, dust mites, cockroaches, and cat dander. Infection, most notably a viral upper respiratory infection. Changes in weather, especially cold air. Exercise. Catamenial or related to the menstrual cycle. And a number of drugs, including aspirin, NSAIDs, beta blockers, and tobacco smoke. For Step 2, the two drugs you should be most familiar with are aspirin and beta blockers. Firstly, aspirin can cause an exacerbation of asthma by decreasing the production of prostaglandins in the lung, which leads to increasing rates of bronchoconstriction. With regard to beta blockers, as you know, beta blockers are primarily used for their effects on the beta-1 receptor in the heart, and by blocking the beta-1 receptor, you can cause a decrease in contraction of the muscle in the heart and a decrease in the heart rate. However, there is some cross-reactivity with the beta-2 receptor, and when you block the beta-2 receptor in the lung, you can cause bronchoconstriction. GERD, or gastroesophageal reflux disease, is another cause of an acute exacerbation of asthma, and this is often better controlled in these patients when you start them on a proton pump inhibitor, and you can sometimes see their asthma symptoms improve as you treat their GERD. In terms of clinical presentation, asthma most often presents with wheezing, a high-pitched whistling noise heard throughout the lung fields on physical examination. Acute onset dyspnea and cough are also very common presenting symptoms of an asthma flare. Some patients will complain of chest tightness or a sensation that they cannot fully expand the chest wall, while still others may have increased sputum production, which is quite common in an asthma flare. Fever is only present sometimes, and most commonly is there when there is a viral upper respiratory infection as the cause of the asthma exacerbation. Remember, all that wheezes is not asthma. In particular, congestive heart failure can sometimes cause wheezing, and a CHF exacerbation is going to be treated very differently from an asthma flare. So it's important to remember that when you hear wheezing, your differential diagnosis must include asthma as well as other disorders such as CHF. Now, let's take a moment to think about some ways that asthma can be tested on Step 2. One way is that they'll ask you for certain signs, either by history or on physical exam, that are very characteristic of an asthmatic patient. Here are some good examples. Symptoms worse at night, nasal polyps, eczema or atopic dermatitis on physical exam, increased length of expiratory phase of respiration. What we mean by this is that the I to E ratio, or the inspiratory time to expiratory time, decreases. Normally, this ratio is 1 to 2. For every 1 second spent on inspiration, 2 seconds are spent on expiration. In a severe flare of asthma, this ratio is going to decrease because patients will have a hard time expiring air secondary to their severe airflow obstruction. Increased use of accessory respiratory muscles, such as the intercostals, hyperresonance to percussion, or sometimes even a pulsus paradoxus can be seen on physical exam. Sometimes on step 2, the presentation of the patient may be quite obvious and may be classic for an asthma exacerbation. However, they may ask you what the best initial test is that you should perform. The answer to this question on step 2 is based on the severity of the patient's presentation. Most commonly on step 2, your patient is going to be in somewhat of a severe asthma exacerbation, as evidenced by severe dyspnea, cough, and wheezing. In this case of a severe flare, the best initial test in an acute exacerbation is going to be an ABG and or a peak expiratory flow. And if given the choice between the two, an ABG would be the ideal test. In the situation of a mild early exacerbation, the ABG may show some mild hypoxia and a respiratory alkalosis, as evidenced by a mildly elevated pH and a mildly decreased carbon dioxide level. In the situation of a more advanced late exacerbation, where the patient may actually be tiring out from overuse of their respiratory muscles, you're going to see severe hypoxia on the ABG, as well as a respiratory acidosis, which will be characterized by a low pH and a high carbon dioxide level. In asthma, the chest X-ray is most commonly going to be normal. However, you may see some degree of hyperinflation depending on the degree of air trapping that's going on. However, the chest X-ray is most useful for excluding other disease processes that may be going on instead of or in addition to the asthma flare. These would include pneumonia, congestive heart failure, or a pneumothorax. Pulmonary function testing is also often used to diagnose asthma, and it is indeed the most accurate diagnostic test. However, it's important to remember that you do not need to use PFTs in the acute setting. Rather, PFTs are best used in the stable outpatient who needs to have a chronic respiratory disorder diagnosed. In order to understand PFTs, you really have to understand lung volumes. So let's spend a minute discussing those in further detail. In order to understand pulmonary function testing, it is critically important to understand the various lung volumes tested on step 2, as well as the terminology associated with these. The first term to be familiar with is the tidal volume, and this is simply the volume of air that is breathed in and out during the normal resting respiratory cycle. You can see on your screen the small oscillations in the center representing the resting tidal volume. The next is the inspiratory reserve volume, or the IRV. This volume represents the amount of air that can be inspired on top of the normal resting tidal volume. This, you can imagine, is if you're breathing normally, and then at the peak of inspiration, you continue to inspire to your very, very maximum intake. That total volume that you just inspired on top of your resting tidal volume is the inspiratory reserve volume. As you'll see, the terminology given to these different volumes makes sense if you think about what each word actually means. Next, we have the expiratory reserve volume. Just like its cousin, the inspiratory reserve volume, this is a reserve volume, meaning that it's an extra amount of volume on top of your resting tidal volume. Only this time, we're talking about the extra expired air rather than the extra inspired air. So to visualize or conceptualize the ERV, think about a person who's taking in normal resting tidal volumes at rest, and then at the end of their normal expiration, they continue to expire all the way down to the maximum so that all of the air that they're able to expire out of their lungs is out. The expiratory reserve volume represents the amount of extra air that was expired after the patient expired their normal resting tidal volume. Next, we have the residual volume. This represents a certain amount of air that will always be within your respiratory tree no matter how hard you expire. Even when a human being voluntarily expires to their maximum, they are unable to get all of the air out of their lungs. That little bit that remains that can never be expired is the residual volume. Next, we have the inspiratory capacity. This one's simple. It's just the inspiratory reserve volume, which we already discussed, added onto the resting tidal volume inspiration. Then we have the FRC, or the functional residual capacity. And this is going to be a sum of the expiratory reserve volume plus the residual volume. The best way to conceptualize the functional residual capacity is to think about a person resting at their normal tidal volumes, just breathing in and out comfortably, and then again at the end of expiration, they expire all the way out to reach their expiratory reserve volume, but then you add on that little bit of volume that can never be expired from the lungs, the residual volume. Those two combined together equals the functional residual capacity. Then we have the vital capacity of the lung. The vital capacity is simply all of the air that a person has voluntary control over. The best way I like to think about this is the total lung capacity, so the entire volume of air that could possibly be inside a lung, and simply subtract out the residual volume, or that little bit that can never be expired out of the lung. And if you take that total lung capacity and you subtract the residual volume, you're going to have the value that is equal to the vital capacity. Then lastly, we have the total lung capacity, which is pretty self-explanatory, and is simply the total volume of air within the human lung. The pulmonary function tests in asthma show the following. Firstly, there is evidence of obstruction, which is defined as a decrease in the FEV1, which is the forced expiratory volume in 1 second, and a decrease in the FVC, which is the forced vital capacity. And that's the total amount of air that someone is able to expire when they're forcing it out of their lungs, regardless of how long it takes to do so. Obstruction, however, is truly defined by a decrease in the FEV1 to FVC ratio. In other words, the FEV1, or the forced expiratory volume in 1 second, decreases much more than the FVC. There is also hyperinflation and air trapping. Hyperinflation is defined as an increase in the total lung capacity, while air trapping is defined as an increase in the residual volume, which, if you look back at the last slide, talked about residual volume as that remaining volume in the lungs that cannot be expired regardless of how much force is given to expiration. There is also evidence of reversibility on the PFTs. Namely, when you administer albuterol or another beta agonist to the patient, you're going to see an increase in the FEV1 of greater than or equal to about 12%, and that is defined as reversibility, which is a cardinal trait of an asthmatic. And lastly, you can also see evidence of bronchial hyperresponsiveness. This is when you administer a cholinergic agent, such as methacholine, which is going to cause some degree of bronchoconstriction. In somebody with hyperactive airways, like an asthmatic, you're going to see a very large decrease in the FEV1. And it's actually going to drop by about 20% of their baseline, and that defines bronchial hyperresponsiveness. At this point, let's pause for a practice question, which is pretty typical of what you might see on step 2. A 15-year-old boy with occasional shortness of breath every few weeks, who currently feels well and has no medications and denies any other medical problems, is sitting in your office with a pulse of 70 and a respiratory rate of 12. Chest exam is normal, which is the single most accurate diagnostic test at this time. Let's take a look at our options. The correct answer is D, a greater than 20% decrease in FEV1 with the use of methacholine. To help us understand this, think about the point that the patient is asymptomatic. This person is not currently experiencing an asthma flare. As we discussed, asthma is a disease characterized by exacerbations where airway hyperresponsiveness results in a transient and reversible degree of airway obstruction. Looking at the other answers which were wrong, peak expiratory flow is not going to help you very much if the patient is not having an asthma exacerbation. In fact, the peak expiratory flow may be quite normal. An increase in the FEV1 with albuterol, again, is not going to be likely in a patient who is asymptomatic. Diffusion capacity of carbon monoxide is something that is used to test how well oxygen is diffusing across the membrane in the alveolus in the lung. If a patient with asthma is not having a flare, they're not going to have any problems with oxygenation or with any gas exchange across the alveolus. So diffusion capacity of carbon monoxide is not helpful in this situation. Same with AA gradient, you're not going to see one if the patient's not having an asthma flare. Increase in FVC with albuterol is exactly the same as answer B, you're just not going to see it if the patient is asymptomatic. Low volume loops on spirometry are good for fixed obstructions, such as somebody with COPD, but is not going to show much in an asthmatic unless they are either having an active flare or have had asthma so severely and for so long that they have some degree of fixed obstruction. Chest CT is not going to show much either, often is clean or just some small degree of hyperinflation. And lastly, an increased ECO2 on ABG is only going to be seen in an acute flare and one that is quite severe and causing carbon dioxide retention. Before we move on to discuss the management of asthma, let's briefly talk a little bit more about diagnostics. Acetylcholine and histamine can provoke bronchoconstriction and an increase in bronchial secretions. Therefore, anything that mimics these two types of molecules can actually be used to diagnose asthma. Methacholine is most commonly used and is simply an artificial form of acetylcholine, which, as we discussed before, can cause bronchoconstriction and is therefore useful in diagnostic testing in an asthmatic. In addition, there are a few other diagnostic tests that will help you to support a diagnosis of asthma, but in and of themselves do not make the diagnosis. These would include a CBC, which may show an increased eosinophil count, especially if the person has other atopic tendencies, such as eczema. Skin testing might identify specific allergens that can provoke bronchoconstriction, increased IgE levels to suggest an allergic etiology, and this can also be seen in allergic bronchopulmonary aspergillosis, which we will discuss in a future lecture. In terms of chronic management for asthma, the best way for you to characterize this in your mind for both your practice and for step 2 is to think about it in terms of a stepwise fashion of progressively adding more types of treatment if there's no response seen in the first level. The easiest way to think about the chronic management of asthma is to divide asthma into 4 different levels of severity. With each additional level of severity, there are a number of drugs that are recommended to be added on. If you remember this chart, you'll have an easy time answering questions about chronic management of asthma on the USMLE Step 2. Step 1 is what you use in patients who have what we call mild intermittent asthma. This is asthma characterized by symptoms less than 2 days per week or less than 2 nights per month. For these patients, there's only one typical therapy used, and that is an inhaled, short-acting beta agonist, such as albuterol, or its enantiomer, levalbuterol. Step 2 is for patients who have what we call a mild persistent asthma. These patients have symptoms greater than 2 days per week or greater than 2 nights per month. So far, all you really have to remember is the number 2. These patients it is recommended to add a long-term control agent. This is typically going to be a low-dose inhaled corticosteroid. The following examples listed are the most commonly seen. So far, to recap, step 1, less than 2 days per week or less than 2 nights per month, short-acting beta agonist only, and if the patient's symptoms persist more frequently than that, you're going to add on a low-dose inhaled corticosteroid. Step 3 is reserved for patients who have what we call moderate persistent asthma. These patients have either daily symptoms or symptoms greater than 1 night per week. Patients, it's necessary to add on a long-acting beta agonist. This has the same mechanism of action as the short-acting, but lasts all day long. Most commonly, these will be salmeterol or formoterol. Lastly, step 4, being the most severe, are the severe persistent patients. These patients have continual and frequent symptoms, despite all of the therapies already mentioned. For these patients, we increase the dose of the inhaled corticosteroid to the maximum dose, and we use one of these long-acting beta agonists and short-acting beta agonist as needed. On the USMLE Step 2, some commonly tested adverse effects of inhaled steroids include dysphonia and oral candidiasis. Some other long-term control agents that we use include cromolyn, which inhibits mast cells from releasing mediators such as histamine or other contents that result in bronchoconstriction. This is most useful for exercise-induced asthma. In addition, theophylline is sometimes used. This is a phosphodiesterase inhibitor, and by inhibiting phosphodiesterase, you increase levels of cyclic AMP in the lungs, and therefore can increase the degree of bronchorelaxation. However, theophylline has known cardio and neurotoxicity, both of which can be tested on the USMLE Step 2. Leukotriene modifiers, including montelukast, zafrelukast, or xyluton, are best for atopic patients. However, you have to remember that zafrelukast in particular does carry hepatotoxicity and has been associated with the development of Churg-Strauss syndrome, which we will discuss in a future lecture. In terms of the management of an acute exacerbation, things are slightly different. The first step, as we said before, is to determine the severity of the asthma exacerbation. If you recall to an earlier slide, this includes a decreased peak expiratory flow and an ABG showing evidence of increased AA gradient, meaning that the patient is not oxygenating well, or evidence of carbon dioxide retention, meaning that the patient's respiratory muscles are no longer able to compensate for the degree of respiratory distress that the patient is in. Either one of those on an ABG is evidence of a severe asthma flare. Remember, peak expiratory flow is basically an approximation of the forced vital capacity. So if you see a patient who has severely decreased peak expiratory flow, you can assume that they're not able to get much air out of their lungs. The degree of obstruction is quite severe. There really isn't any precise normal value for the peak expiratory flow. You have to remember that it's based predominantly on height and age and not the patient's weight. It's used in an acute assessment by basically seeing how different this number is compared to the patient's known baseline when the patient is stable and not having an asthma flare. The very first step in the management of an acute exacerbation of asthma is to add on oxygen. As simple as this might seem, Step 2 often likes to test the initial step in an unstable patient. You always have to remember your ABCs, airway, breathing, and circulation. Therefore, in an unstable asthmatic, the first step will be to put oxygen on the patient. Albuterol is then given, often in the form of nebulization, in order to ensure adequate delivery to the lungs. Sometimes inhaled anticholinergic agents, such as ipratropium, are also given, again, in effort to decrease the amount of bronchoconstriction contributing to the asthma flare. Corticosteroids are also the mainstay of treatment in acute asthma exacerbation. These need about 4 to 6 hours to begin to work, so they must be administered immediately. Whether you give them orally or intravenously does not make a difference, but they must be given immediately. Epinephrine injections are no more effective than albuterol and actually have more systemic adverse effects So in the adult asthmatic patient, we typically do not give epinephrine for an acute flare. As mentioned on the last slide, anticholinergic agents are sometimes used in the setting of an acute asthma flare. However, it is worth noting that really no large trials have ever demonstrated that either ipratropium or its long-acting version, tiotropium, have been particularly useful in the role of asthma management. However, because these drugs do work well for other obstructive lung diseases, and because their mechanism seems to make sense to treat an asthma flare, we do often use them. Ipratropium is the one of choice. However, it does not work quite as rapidly as albuterol. And again, epinephrine is rarely used in the adult asthmatic patient and is really only a drug of very last resort. Sometimes, the role of magnesium is brought into question for an acute asthma flare. It does have some modest effect on bronchodilation. However, it is not nearly as effective as albuterol, ipratropium, or steroids. However, with some degree of help, it is sometimes worth giving. It does help with bronchospasm, and it's used only in the acute severe asthma flare that's not responsive to several rounds of albuterol, and while you're waiting those 4 to 6 hours for the steroids to take effect. For some patients, in particular those with severe persistent asthma, they can end up on chronic systemic steroids for very long periods of time throughout their life. It's worth noting the adverse effects of chronic systemic steroids in these patients so that we can avoid giving them unless absolutely necessary. Osteoporosis, cataracts, adrenal suppression and fat redistribution, in particular you see fat in the abdominal distribution, hyperlipidemia, hyperglycemia, acne and hirsutism, particularly in women, thinning of the skin, striae, and easy bruising are also chronic effects of systemic corticosteroids. While we already touched briefly on the adverse effects of high-dose inhaled steroids, it is worth noting that these rarely lead to those same adverse effects associated with prednisone or systemic steroids. Remember, inhaled steroids are only likely to cause some thrush or oral candidiasis or some dysphonia. They're not going to cause the previously noted side effects of systemic corticosteroids. At this point, let's pause again for another practice question. Here, we have a 47-year-old man with a history of asthma coming into the emergency room with several days of increasing shortness of breath, cough, and sputum production. The respiratory rate is 34, and he has diffuse expiratory wheezing and a prolonged expiratory phase on physical examination. Which would you use as the best indication of the severity of his asthma? The answers include respiratory rate, use of accessory muscles, pulse oximetry, PFTs, or the pulse rate. In this case, the correct answer is A, the respiratory rate. A normal respiratory rate is 10 to 16 times per minute. Therefore, by itself, a respiratory rate of 34 indicates severe shortness of breath. A patient breathing that rapidly will not be able to maintain a rate that quick for very long. Eventually, respiratory muscles will fatigue, and the patient will develop respiratory failure. The wrong answers here are B, C, D, and E. B, use of accessory muscles, is wrong because it's quite a subjective measure and is hard to assess. Certain patients, especially those with large body habitus, may not show you use of accessory muscles on physical exam. Pulse oximetry will not show hypoxia until the patient is very advanced in their asthma flare and at the point of an imminent respiratory failure. In fact, oxygen saturation can be maintained above 90% for very, very long time simply by hyperventilating. Truly, it's the respiratory rate and the potential for respiratory failure that is more important. Pulmonary function testing is not going to be useful when a patient's acutely short of breath. In fact, the patient won't even be able to cooperate with the necessary tests. Lastly, pulse rate does not add much in the situation of impending respiratory failure. It is worth noting that there are a number of medications which are not effective in acute exacerbations. Sometimes, step 2 will test you on these, so it is worth remembering. Theophylline is good for chronic management. Cromolyn, also good for chronic management, in particular patients with extrinsic allergies or exercise-induced asthma. Leukotriene modifiers, again, are good for chronic patients and for preventing asthma flares, but not necessarily in the setting of an acute exacerbation. Omalizumab is a monoclonal antibody, which is sometimes used in the chronic management of asthma, but again, not helpful in an acute flare. Lastly, salmeterol, which we already mentioned, is a long-acting beta agonist. This is used as a controller medication to prevent asthma exacerbations. It is not helpful to administer in the setting of an acute flare. If the patient does not have a response to your initial therapies, or if they develop a respiratory acidosis on their ABG, the correct answer is going to be endotracheal intubation and mechanical ventilation. In this situation, the patient has not responded to your initial treatments and is starting to show you, via the increased PCO2 on their ABG, that they are developing respiratory fatigue and impending respiratory failure. The only way to reverse this process is to take over the patient's breathing for them by using an endotracheal tube and a mechanical ventilator. This concludes our lecture on asthma.